Alright guys, let's talk a little bit about burns. So let's do the burn basics. First, stop the burning process. If it's a chemical burn, that's a thing, but if it's a regular burn from flames or house fire or anything like that, biggest thing is get them away from the fire itself. The second part of that is keep them warm. Once you lose that burned skin, it's really hard to thermoregulate, right? So keep the patients warm best you can. Last part, prevent further injury and keep them clean. First three basics of burn care. Something to remember with burn patients, trauma always trumps burns. Patients with concomitant trauma, the trauma is what's going to kill them first. So always prioritize definitive management with trauma care before burn care. Burn is considered the secondary injury when concomitant trauma is present. Again, hemodynamics, the patient needs blood, give them blood. Don't necessarily worry about the consensus formula or Parkland formula and the volume resuscitation. Handle the hemodynamics with what's going to kill them first, right? Patients with concomitant trauma should go to a trauma center that is capable of managing their traumatic injury over a burn center. Now, ideally, you go to a trauma center that can handle both, but prioritize definitive management. Don't worry so much about the burn, manage the trauma first. Now then, before we get on to fluid, let's remember, fluid, large bore IVs, greater than 20% burns. A lot of people ask, well, how do I figure out what percentage the burn is? Let's remember the Lund-Bauer chart or the rule of nines. So let's talk about it real fast. So for percentage, let's talk about the rule of nines. So remember, the palm of the patient's hand, not your hand, the patient's hand is about 1%. So if you want to, you can take their hand, draw it out on a little piece of paper, and then put it in blobs. That's usually pretty good for figuring out small percentages of things. So when we want to use percentages beyond that of 1% or small percentages, typically we go to estimation with using the rule of nines. The reason why it's called the rule of nines is it's in factors of nines. So I just remember my ABCs. So my arms and head, which are alphabetically first, those are typically 9% each. So each arm is about 9% in its entirety. So 4.5% on the anterior, 4.5% on the posterior, and then my head as a whole is about 9% as well. 4.5% on the anterior, 4.5% on the posterior. You kind of get the picture. Next, legs. So each of my legs is about 18%. Last part, trunk. Trunk is about 36%. And then the groin area is typically about 1%. So when you work it out for the rule of nines, arms and head, 9, legs, 18, trunk, 36, groin, 1. When you add it all up together, 100%. Now, when we talk about pediatrics, it gets a little bit different, right? So kids have a lot bigger head, so their head's going to be a higher percentage. So let's talk about infants. You can look at the chart next to us and kind of follow along. For heads, typically 21%. For arms, about 10%. Trunk, usually about 26%. Each leg is about 13%. And the buttocks and the groin is about 6%. So let's talk about volume resuscitation. So any patient that's greater than 20% total burn surface area of second degree or higher partial thickness burns is going to require volume resuscitation. The ABA changed its guidelines in the last several years, especially for pre-hospital, which is great for our pre-hospital friends because now it's just fixed rates. Less math, easy to remember. Patients that are 5 years and less, they're going to be 125 cc's per hour. Fixed rate, good to go. Ages 6 to 13 are going to be 250 cc's per hour or 250 mLs per hour. Adults, you guessed it, 500 mLs per hour fixed rate. This is all until you get an estimation on burn surface area so you can work forward to the formula. So there have been a lot of formulas that people have come up with over the years for burns. Parkland's probably the most famous, but what everybody's moving to, according to the ABA guidelines, is the consensus formula, which is also pretty simple as well. So let's work on it. For adults, we're going to do 2 mLs per kilo per total burn surface area percentage. That's estimated. For pediatrics, we're going to do 3 mLs per kilo per total burn surface area. And for electrical burns, 4 mLs per kilo per percent total burn surface area. That's going to give us our total volume over the first 24 hours. Just like a Parkland, the half of that total 24 volume is going to go in the first 8 hours. Fixed rate, good to go. For pediatrics, we're going to make sure we add a little bit of glucose so they have glucose-containing fluids. We don't want their glucose to drop too fast, especially these kids if they start shivering or if they're hypothermic, they're going to burn through that glucose a whole lot faster. As soon as that metabolism increases, so does their sugar use. Now then, for a lot of people ask, what kind of fluid should I use? The biggest thing is something balanced. LR is still the preferred fluid across all burn patients. If you don't have LR, Plasma-Lyte may be a good option. Last ditch, of course, normal saline. We don't want to give these patients any boluses unnecessarily, but you may have to. But try to stick with the straight volume over a set period of time. So let's do a quick example. Say I've got a 110 kilo patient that's got 34% third degree burns from a car fire. Let's do the math. 34% times 110 kilos times 2 mLs, that gives me 7,480 mLs. So that's the total volume they're going to receive over the first 24 hours. Now they're going to get half of that in the first 8 hours. That volume is 3,740 cc's. So we're going to divide that by 8 hours, and that's going to give us 467.5 mLs per hour. That's our rate for the first 8 hours. Now we still have to figure out the rate for the next 16. What if we're dealing with a transfer, a patient that's already had 6 hours of fluid? We're going to need to swap them over in the transport. So for the next 16 hours, their rate's going to be 3,740 divided by 16. That rate's going to be 233.75 mLs per hour. That's going to be for the next 16 hours. Now all this volume resuscitation we're talking about in burns is right up until you get a Foley. So Foley should be placed as early as possible in burn patients because we want to make sure they have good renal function and perfusion, and urine output is a great indicator for that. So for adults, we're going to do a greater than at least 30 mLs per hour or 0.5 to 1 ml per kilo per hour. For pediatrics, our target rate is going to be 1 ml per kilo per hour.